2014, I became the senior medical advisor. Actually, I was chief medical officer of the state association, Ohio Association of Community Health Centers. Very much like Pennsylvania, it's the PCA for the state. They didn't have a chief medical officer before then, so I created the job. And of course, I didn't know what I was supposed to do, but I got to make it up. So when I asked the members what they needed and what they wanted, number one on their list was workforce. They had workforce needs, trying to recruit docs, nurse practitioners, PAs, social workers, others was a real challenge for them. So they said, if I would just recruit all the people they need, they would all be happy. So I said that I'm not that good. I said, I can't recruit all the people that you guys need, and I'm not a recruiting agency, and I have no other staff. So what I might recommend we try to do instead, plus I didn't think it would work very well. I said, what I might recommend you consider doing instead is growing your own for the future, because you've all been using agencies and other resources to bring people in, but there's a lot of turnover. It seems to me that more than I would like to see is occurring that way, largely because people are coming in that don't know you, haven't worked with you, and you don't know them. You're interviewing them, hiring them, and then trying to keep them retained on staff. So I said, my preference would be you develop continuously learning organizations, CLOs, like IOM says we should all be doing. And I think the best way to do that is to teach. So they did not see themselves as teachers, most of our FQHCs, and they said they didn't know that they could do that. So I asked, what would they need to be able to teach? Well, some of it was technical skill development, but a lot of it was other barriers. They didn't have space. They didn't have a place for students to stay. So housing was an issue. The students mostly, though, they said, would take them away from their revenue producing productivity formulas that they were on, because we're all on that already. So there was a financial perceived barrier there, and a number of other barriers, you know, buying licenses for computers and all these other things that students bring with them, and a staff to coordinate and organize that. So what I said to them was, let me work on the barriers to teaching more than going around and recruiting, you know, students and residents and graduates into you. So it just happened that year in 2014 that Ohio decided to expand Medicaid. And it was very surprising to all the Republicans in the state that our Republican governor, John Kasich, would do that. But we convinced him to do it. I was on his cabinet the year before, and we had convinced him to do that because we said it's in the best interest of the public, and he got strongly behind it. So when we advanced Medicaid, what happened was there was a state line item of support for our FQHC statewide for taking care of the uninsured. Well, once the decision was made to expand Medicaid, it was perceived by everybody that, wow, the uninsured will like disappear. They're going to be gone. So the FQHCs won't need that line item of support anymore. So sure enough, when we looked at the governor's budget, I was already out of the cabinet at that time and working with the FQHCs, but we looked at the governor's budget and he had zeroed out that support line for the FQHCs, which was about $2.5 million a year that was spread amongst all the different FQHCs that were doing uninsured care. So that was zeroed out. And so what I did was I went with our staff to the governor's office and said, why don't we, rather than zero that out, let's go ahead and repurpose those dollars towards a common goal we all have, which is enhancing primary care in the state of Ohio, because we don't have enough. We got all this data, all this information that says we're in trouble and it's going to get worse by 2025. Let's take that money and change it into supporting teaching in federally qualified health centers for a variety of different reasons, mostly because I thought it's the best place for a student to learn comprehensive care provided by a coordinated team group of caregivers from multiple disciplines that students generally didn't see on their academic campuses. More importantly, it was happening in underserved areas, taking care of people in need, and critical to the state of Ohio, Medicaid patients, which were more than half of our patients, were struggling to find providers to give them care. So with a variety of different approaches, after leaving the governor's office, they said, go ahead and do that. We will not stand in your way when you try to do this in the House and Senate health committees. They said this on a Friday afternoon. Monday, they called me and they said, never mind, the governor's putting it in his budget because he wants to own this thing. So I said, great. We got to some common interest and benefit coming from this. So it went through the House, went through the Senate, got preserved, and so it's around $5.5 million today that goes into the biennial budget. 2.5 million or so a year can be used. And what I do with this is we host over 1,000 students who rotate through our federally qualified health centers every year. So you'll see my data there for a 5-year total, but it's over 5,000 students that have had clinical rotations. Those students come from medical students, nurse practitioners, PAs, dental students, and behavioral health students. And the legislature helped define who was going to be targeted. I don't have pharmacists in there, I don't have some other people in there, and you can argue it back and forth, but this is the best I could do for coverage. And when those students rotate through our FQHCs, then their hours are tracked, and then I am billed by their center, not by the individual preceptors, for hosting the students. I send the support to the C-suite of the center, so they will get behind teaching in their center and not to individuals who are doing the teaching. So some of them choose to use it to acknowledge preceptors and what they're doing. Some of it use it to make up for what they see as a deficit in productivity that happens from teaching students. Some of them house students in housing in their, because they're rural settings. Many of them have bought computers, created space for students, put libraries in and all those things. I don't tell them how to do it, and it's not required that they tell me exactly how they use the money. I'm just trying to get the C-suite off the back of my preceptors so they don't give them a lot of crap when they're trying to teach and say all the reasons they can't teach because it's hurting the center. It's not hurting the center. It's not totally making up for the time and expense, I'm sure, but it's a significant stipend that goes to each of the centers to really basically help them support teaching on site. So to date, 51 of my 57 FQHCs participate in this program. But to be paid by me or to be eligible, you have to be PCMH recognized, or I don't pay. I don't pay if you're not demonstrated to have done the work to demonstrate to the students that you know how to do patient-centered care. And I also don't pay them if the student doesn't rate their experience at least a 4 out of 5 on a 5-point Likert scale. So I hold them accountable for good experiences by the student. I also require all of my teachers to participate in our training programs that we have, and we host training programs throughout the year, and part of the funding goes towards preceptor training. Then we also, with the centers, encourage, we don't demand, but I encourage strongly that all of the teachers become faculty members at the various institutions that we work with. And we work with, I think, about 150 different programs around the state who provide us with students of various types. They have to report quarterly to us, the different centers do, and they report at the end of a student rotation so that the student, because some of our students go 17 months there. I mean, some of our students come on as first-year medical students and they stay 17 months. I don't pay for them until they finish. I don't do anything along the way. It's too bureaucratically cumbersome. We try to keep it simple. We have monthly meetings of our points of contact. Every center has got its own point of contact. And so we organize that. Preceptor meetings we have on a regular basis. We have annual meetings with speakers where we make sure that we highlight to the state, what we're doing and what the outcomes have been that we've produced with this program. So what everybody wants to know is what happens to these students. Does it make a difference? Well, tracking students, as you might know, is not easy sometimes because they move, they leave, they go on, and they don't stay in touch with us. They don't like call me up and go, hey, guess what? I just got a residency position at this residency program. They don't do that. So we track them by licensure, by NPI numbers, by lots of other ways to keep track of where they go. We know to date of those 5,000 student rotations, which was probably about 3,500 students, I would guess, because some of them do 2 rotations with us. Some do even 3 because they like the experience so much. But of those, I know 615 have been hired by my FQHCs in Ohio already. 615 in a 5-year period of time. That's probably better than I would have done if I was calling around trying to get people, recruited in, or went to recruitment fairs and did all the other stuff I did. But the real benefit is all my centers that are teaching have become better. That is, you remember, teaching is learning twice. they are now very much current in their information base. They're working with students and developing new skills all the time, not just the teaching, but also clinical skills. They're staying very much up to date on what's going on in the medical world. And the students are seeing modern healthcare being delivered because they're all fully electronic. We've got a population health monitoring going on in all of our centers using sophisticated tracking systems that I want the students to see. And our students are using the electronic health records, inputting information with proper supervision. So they're getting a look at not a rejuvenated grocery store where second-class care maybe is being given by people writing on 3x5 cards. They're seeing the most modern healthcare delivery system provided by physicians, nurse practitioners, dentists, social workers, pharmacists. We've got vision services in many of our centers now. I've got chiropractors, we've got podiatrists in some of them. We've got an expansive group of different professionals working together. Where else is the student going to see that all in one place? It just isn't going to happen in most other settings. So I've convinced the legislature. I get zeroed out every 2 years in the budget, and I have to go back and get my money back. And actually last year I got more money than I wanted. They gave me more money than I asked for because people thought this is a damn good idea. So this year, first year since I've been here, that I wasn't zeroed out in the governor's budget. He actually put us in there at $5.4 million level. And so, we're thinking like they're finally starting to understand what the need is of the state, what the best way to get at it is, because these students, when they're graduating, are staying in primary care. They're staying in Ohio, which the legislature is very interested in, because we were net exporting for a long time. They're taking care of the underserved. We're now tracking how many are in HIPSAs and medically underserved areas also, not only in Ohio, but outside too. They're taking care of Medicaid patients, and we're assessing that through Medicaid billing data. So with all this now access to information that we have, we can actually track people a lot better than we used to when we, like alumni societies, would have to depend on people responding to emails. We can find them now. It takes some effort, but you have to do that effort to justify the program. Otherwise, if I were them, I'd give them my money back. If I can't justify it. Remember, I worked for the state for years. I was used to getting grilled every year to prove why I needed to have what I had. So we've responded with, I think, a program that's very credible. It's have really important criteria for participating, for actually receiving any of the funding. And then we mandate, we'll follow every single student that's ever been through any of our centers for as long as this program exists. So we're now in our 6th year of operation now, and we get more requests, of course, for rotations than we can possibly provide. But it's nice to see that so many students not only want to come to us, but so many academic institutions want to send their students to us, largely because of the evaluations the students do of their experience. And some of the things they write, it's sort of like, I think what Judd and others were pointing out, some of these things that students write are just amazing about their experience, like Lauren had with her students upstream. Those kids' lives are changed by these experiences. And the most common thing we hear is, I never would have known this existed. I didn't know it was possible to provide the kind of care I went into medicine to provide and still make a living, be able to make a living. And third, I always assumed that if that happened, it would be second-class care, basically is what they're saying. I didn't know you'd get the latest and greatest of tools and capabilities that would come with it. So they tell all their friends about it, which is great. And so we're really helping students understand, even if they don't come and join us, that's fine with me. They become a neurosurgeon. I want them to know what an FQHC is, why it's there, what it takes care of, what its purpose is, and that we haven't forgotten the underserved and those in need, and that you also don't have to, go bankrupt trying to live a life where you take care of people in need. You can actually do it and be relatively well supported, both by personnel and financially. So we're getting the message out. It's been a very successful program for us. I'm just really surprised that every state hasn't done this. But this took the cooperation of all of my membership to do this, because they had to agree to let me repurpose the money they were receiving, because almost all FQHCs and PCAs, I think, they're flowing some dollars from the state into some way of helping them. Maybe Pennsylvania doesn't do it, I don't know. But I know Indiana and lots of other states, they get dollars in and it goes out to those different FQHCs, and it recognizes the fact that they're still taking care of people in need and aren't getting paid. In Ohio, we started at 34% of our patients when I began were uninsured. Well, even with Medicaid expansion, it's still 16% now. They didn't go away. They all just came to FQHC. So we're getting all of those people that choose not to be insured or aren't eligible. So I really appreciated our membership agreeing to give me those dollars that they were spending to make up their deficits in care for the uninsured and invest in, it's a huge investment in creating the workforce by actually teaching them in their health centers and then putting them to work in their health centers ultimately as a better way. And in the process, making my health centers better as continuously learning organizations. They are improving the care they provide. They're improving each other. So what we're also tracking now is retention. Because my philosophy is that if you spend a month or two with somebody and then you hire them, your chance of retaining them is a hell of a lot better than if you interview them for an hour or two at dinner time. And I mean, I know which fork is the right one to use maybe, and I might know some other things about them, but I have no idea sometimes if they're going to actually fit in well in my organization. You spend a month or two on rotation, you know all about that person. You know their traits, you know their qualities, you know their concerns, you know their work ethic, you know about their family, you know everything about them. And those you want, you go after vigorously. And those you don't, you let just continue to pass along. But you have a good method for at least discriminating and discerning who is a good fit. And goodness of fit is that critical component that is hard to sometimes pick up on a quick interview. So I'm just here to tell you that's one way of doing recruiting, right? It's one way of doing it. But I think there's a whole bunch of benefits of taking that approach. And it seems to be working pretty well for us at this point in Ohio. So that's all I wanted to say. And if you want the numbers and detail and all that, it's all in that slide deck that I sent you in the chat line. So you can pop into that when you're really bored sometime and you want to look at some of that.
Thanks so much.
That's all I got. So Larry, back to you.